And then last, Dr. Manu, PRIYA. So she'll present on effect of ND-AG laser posterior capsulotomy on refraction, IOP, and macular thickness. First two presenters who are not there, Deepak Chaudhary has come? No.
First one is not there.
Deepak Chaudhary has not come, and second, Dr. Sunita is also not here, no? Fourth one, sorry. Kanika Bharadwaj, yeah, she is not there.
Good afternoon, everyone. The topic for my presentation is effect of amount of energy used in ND-AG laser posterior capsulotomy on refraction, intraocular pressure, and macular thickness. So basically, posterior capsular opacification is the most common late complication of cataract surgery by means of any ECC procedure. And it usually occurs, it can even be per-op PCO, but it usually occurs between 1st to 5th years post-operatively in about 7 to 31% of patients. And usually we see the incidence that is reported around 10% at the end of 1 year, 20% at the end of 2 years, and 30% at the end of 3 years. The reason for occurrence of capsular opacification is the continued viability of lens epithelial cells. Now, there are factors that affect PCO formation that include age, history of intraocular inflammation, presence of pseudoexfoliation syndrome, size of the rhexis, cortical cleanup, capsular fixation of the implant, design of the lens implant, modification of the lens surface, and time elapsed in surgery. Prolonged use of post-operative topical corticosteroids or NSAIDs do not seem to play a role in the rate of PCO formation. PCO is now routinely treated by the ND-AG laser capsulotomy with significant visual improvement in most cases. Now, laser capsulotomy uses a quick pulsed ND-AG laser to apply a series of focal ablations in the posterior capsule and thereby creating a small circular opening in the visual axis. Although it is a relatively effective and safe procedure, laser capsulotomy may cause complications including transient intraocular pressure elevation, hyphema, uveitis, CME, and retinal detachment. Apart from this, mechanical effects can occur such as pitting of the IOL, dislocation of IOL into the vitreous, and shift in the position of IOL. Explanations for the rise in IOP following ND-AG laser capsulotomy include a deposition of debris in the trabecular meshwork, trabeculitis, neurovascular mechanisms, pupillary block, and inflammatory swelling of the ciliary body or iris root. This procedure also causes a change in the position of the implant, which can cause a change in the effective power of the lens in the eye and potentially alter the refraction of the patient. Macular edema occurs due to the movement and damage in the vitreous cavity and release of inflammatory mediators due to damage of the blood-aqueous barrier. The aim of the study was to study the effect of amount of energy used during ND-AG laser posterior capsulotomy on the refractive status, IOP, and macular thickness. This was a prospective observational hospital-based study which was carried out over a period of 6 months in a tertiary care center. Patients were presenting to the OPD within the given time period and fulfilling the inclusion criteria were included in the study. So only the cases that had undergone uncomplicated manual SICS or phaco with PCL implantation in the back were included. Exclusion criteria were any complications occurring during the surgery, glaucoma, cornealopasties, retinal diseases, uveitis, optic neuropathy, and any active ocular inflammation. Total 72 eyes were included in the study. Detailed history and a preoperative examination was done. Patients were divided into 2 groups on the amount of energy used. In group A, less than 50 millijoules of energy was used, and group B, more than 50 millijoules. And the eyes were anesthetized using Paracaine, and a capsulotomy size of 3 mm or more was considered adequate. Post-operatively, the patients were given moxifloxacin 0.5% plus dexamethasone 0.1%, and patients were examined at 1 hour, 1 week, and 1 month post-procedure. Now, in group A, the total mean energy used was 24.48, and in group B was 76 millijoules. And according to the age and male to female ratio in both the groups was similar in both the groups. And as we can see, the BCVA had increased significantly from the pre-procedure level at both 1 hour, 1 week, and 1 month post-operatively. And the difference between the 2 groups was insignificant. There was a significant rise in IOP in both the groups at 1 hour, 1 week, and 1 month. However, at 1 month, the IOP returned to pre-operative levels in group A, but it did not return to preoperative levels in group B. There was a significant difference. And same goes for central macular thickness. It increased, but in group A, it decreased to preoperative levels at 1 month, and it did not decrease to preoperative levels. There was a significant difference in group B. So the reported incidence of PCO is around 20% at 2 years and 28.5% at 5 years. And the most common complication of ND-YAG laser posterior capsulotomy reported is increased IOP. In the absence of any anti-glaucoma or anti-inflammatory prophylaxis, around 59 to 67% of patients showed IOP increment. Despite the prophylactic treatment, increased IOP has been reported in around 15 to 30% of patients. However, in a few studies, they have reported no increase in IOP at all. Another similar study by Eri et al. Divided the groups according to the energy used as less than 80 millijoules and more than 80 millijoules, and they reported similar outcomes. Now, Findle et al. Reported a subtle posterior shift of the PCIOL occurring along with deepening of the interior chamber. However, in other studies, they failed to observe this effect. Ari et al. Also noted significant increase in the macular thickness following ND-YAG laser posterior capsulotomy, and the increment was higher in patients who received higher energy. In the present study, we noticed significant change in BCVA post-procedure. There was transient increase in IOP in group A, which returned to pre-procedure level at 1 month. However, they did not return to pre-procedure level in group B. Limitations of the study are small sample size, less duration of follow-up, and potential IOP rise due to topical steroids was not taken into account. Also, the type of PCO was not taken into account. So to conclude, the IOP rise in macular thickness increase is higher with higher energy. However, it may not always necessitate any medications. Thank you.
Because no other presenter we allowed you. You have taken almost six minutes. Not followed the
Sorry.
4 minutes. Okay, anyhow, we'll.
No. Are you a postgraduate student?
No, sir, I'm a senior resident.
Huh. And why did you use an antibiotic-steroid combination in this post-YAG?
Sir,
Please don't. Just give
Okay.
steroid
Okay,
if you
sir.
want to give steroid. Huh? Maybe their
So that
hospital
was the
gives it like that.
I
And
had
so
this study I had done when I was a postgraduate resident, 3rd year.
No, you should question existing rules even
Yes,
as a
sir.
postgraduate resident. Okay. So
Definitely.
next thing is why would hyphema be a complication in if you do a proper capsulotomy?
Sir, like any complication, like if we injure the iris in some case.
So some cases they would have hit the iris also.
No, it didn't happen, but it is
Possible.
it is
Anyway,
a
so
possible
please focus only on the
complication.
capsule.
Ye-
And
yes, sir.
otherwise, this is a age-old thing which has been being told from ages, capsulotomy and its complications and all those.
So the basic thing was
Good.
like, do we need to give anti-glaucoma and NSAIDs post procedure or not? So as you can see,
Your significant rise in IOP is from 13 to 15, 13 to 16 and all
yes, sir,
those.
but the p-value is coming as
That's what.
significant,
So
that's why.
p-value and clinical correlation is something which you should understand.
Yes,
We should
sir.
all take into consideration. P-value may be high. But when
Huh.
you say clinically, somebody's IOP going from 13 to 16 and coming back to 15,
Huh.
which are all clinically very irrelevant things.
yes,
But
sir.
then still, keep all those in mind. When you present that it is a significant thing, it has to look significant also.
Yes, sir.
But otherwise, good.
Thank you, sir.